Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And we have a special guest today, and Raafae, if you want to introduce him.
Yeah, so this is Dr. Ram, a UK podiatrist and a influencer, right? I've followed you on TikTok and social media platforms. You're known as the Good Foot Doctor, correct?
Correct. Yeah.
So
I followed you as well, so I'm a big fan of your videos you put out.
Yeah, it's the new marketing campaign, right? It used to be that you go out and you go door to door, shake hands, kiss babies, but now marketing is all social media based. So I like that you're doing all that.
I appreciate it. It's quite hard work because you've got busy lives and you're working usually to create content. It's
a full-time job, I agree.
Which has become the norm.
So you're a podiatrist from the UK, and I know the training there is different. You go from high school straight to podiatry school, right?
Correct. Everything is an undergraduate. Medicine, dentistry, nothing's a graduate. Correct. There are a few which used to be like, there's a career called audiology. That's also become an undergraduate. But the whole idea is because we have A levels, but we're in college. So we do chemistry. If you're trying to get into like medicine, obviously the requirements are chemistry, biology, perhaps maths or physics. So you're learning all that, and that's quite of a high level. So then to jump into university, you're able to do that's the English system, which has been there since the dawn of time.
So how long is the training after high school?
It's 3 years for podiatry, no problem. Other careers like medicine, it's 5 years. I think, dentistry is 5 years as well. But for podiatry, it's very it's very packed. Like for 3 years, you're doing quite a lot.
So the first 2 years are like your undergrad, and then the last 3 years are your medicine-based?
No, it's all undergrad 3 years. But the thing is, before I did podiatry, I actually studied biomedical science. I was doing a degree in that. So I can see the difficulty in podiatry because it's you've got oral exams, there's clinical exams, and it's not a pass or fail. It's like an honors degree. So I think that it's quite demanding in that sense, and quite subjective too, if you ask me.
Yeah, I could imagine so. What about training afterwards? Do you residency, internship?
We don't, because that's one of the kind of like pros with podiatry is like you can go after you pass exams, then you register with the HCPC, which regulates the licensing. Once that's approved, you can start working. But if you want to do further training, you can actually do it's a master's in podiatric medicine, theory in podiatric medicine, and that gives you the kind of like passport into becoming a podiatric surgeon. You don't need to do the full masters. I think you just need to do 1 year, which is a certificate.
Wow. So for those of you who don't know, when we go through school in the US, you're doing your undergrad for about 4 years. If you can rush through it, 2-3 years, hopefully, those accelerated programs. But then you do 4 years of med school, podiatry school, whatever, dentistry. And then after that, you do your residency, which is a minimum of 3 years, and then fellowships or whatever other advanced training you want to get going. So I like this idea of not wasting your time in undergrad, because I truly believe undergrad is a waste if you know what you want to do. 4 years wasted, while if you go to the UK, and in a lot of other countries, I know like a lot of Asian countries, China, India, Pakistan, you're doing right from high school to your medical training. You're going, 4, 5, 6 years, and bam, you're set.
I think everywhere around the world it's like that. But I like, for me, because I'm coming from outside into the US, I find that quite fascinating to do 4 years of undergrad. I think it should be 3 years though. But then you can choose.
2 years.
You're quite young. You're 16, 17. And you've got to make a decision. You don't know what to get into. You might not be seasoned yet. Because I've had some friends who actually wanted to become doctors, but they didn't get they didn't get the grades in the A levels to make it. So what they did was because now they introduced fast track medicine, which is 4 years for graduates. Wow. It's a graduate entry medical program. In the last 10 years, so many of those have been opening up. So if you've got a bioscience undergraduate degree, then you can apply for graduate entry medicine. So that's been also another option.
Yeah, I like that idea. No time wasted. You know what you want to do. Jump right in, head first, and get the training you need.
Yeah. But having said that, because I've got nephews who are in school and they're going to studying, and I can see that it's actually better because you've got a lot of time. You see, I know you're losing time, but actually, as a child turning into an adult, you've got a time to actually learn. You can choose your major as well. So it's a lot of flexibility, but yeah, it takes a bit of time, that's all.
I think you're right. I think you're missing the social aspect of undergraduate training and the ability to mature at the same time. So I certainly don't think I was ready for graduate level medical education until I was 22. So I spent 4 years figuring it out and had a really good time doing it. So yeah, don't miss the social aspect of it.
That's true. Now, what's the scope of practice being a podiatrist in the UK? Are you doing surgeries mostly, clinical, wounds, ulcers, amps, big surgeries, I don't know, ankle replacements? I mean...
Sure. So I'll start from the top, but basically when you qualify as a podiatrist and then you get licensed, you can do anything apart from podiatric surgeries. You can do non-invasive procedures. So anything which isn't surgically, apart from nail surgery, I mean, yes, that's the only surgery that you can actually do. So coming down on that, the biggest need for podiatrists is diabetic wound care. So that's the biggest thing which keeps the profession alive, because anything else, because we have a government system called the National Health Service, everything works on their criteria of what they need for their hospital, or because we have trusts, community settings, so everyone creates their own criteria, they've got their own, almost like a company. So it doesn't matter so much about what profession you're from, because we have nurses, doctors from different specialities. It's about what the clientele needs, what do they need. So wound care, diabetic wound care is very extremely high need. So that, I've got to say, in the UK, like, that's one of the biggest areas of expertise for podiatrists, where I started debriding diabetic wounds when I was in my last year of university.
Oh yeah, I would agree. Even here in the US, diabetic foot care, ulcers, wounds, very common. We just started with a wound care clinic of our own just because it's become so prevalent in the practice.
Yeah, I think
that's one of the niches of podiatry. Because no one, it hit me because I was thinking about this podcast, there's no one who's actually doing it. They can, but I've been looking at nurses, they can actually, but the few of them can debride. But then again, all of them lack the biomechanical knowledge to offloading. Few, doctors from vascular surgeons, they've got a good knowledge, but they don't like touching wounds. They go, I'm not touching that. Dermatologists, some of them do, but again, they don't. It's not really. No one was doing it, to be honest with you. So it's kind of like a new thing that's come up, and also because there's an increase of people who have diabetes and become high risk. So that's all kind of changed the game of podiatry.
So you asked me before we started about the peripheral nerve work that I do. A large portion of that is trying to turn around sensory loss in diabetic patients. And we're able to do that to a certain extent when we catch it at the right time by doing neurolysis or decompression procedures on the tarsal tunnel, common fibular nerve, deep fibular, superficial fibular nerves, and allow patients to retain their protective sensation. And that's something that was, heresy 30 years ago. but we have a large multi-center randomized controlled trial being done right here in Dallas at UT Southwestern. And it's an ongoing study that's probably going to produce a dozen papers on the applicability of that surgery in turning around patients who are heading down the wrong path. So yeah, I think that my practice is revolves around trying to save that diabetic limb, both from a peripheral nerve standpoint and from an architectural standpoint, doing Charcot reconstruction, doing the deformity correction that's required to try to prevent recidivism. So
yeah, and I've seen a lot of that done in the UK actually. A lot of the hospitals which had podiatric surgery units did some of that work. And again, every place was commissioned differently, because some places orthopedic surgeons would also overlap.
Sure.
It all depends on which place you were working in.
I think the orthopedic surgeons, again, they're another group that probably isn't that interested in treating the wounds. And they certainly didn't really have the expertise with the peripheral nerve.
Yeah, I think that's the whole why podiatry emerged, podiatric surgery, particularly in the UK, because orthopedic surgeons, they didn't really have interest in the digits, in the forefoot. Right. They were more interested in the knee, anything above, because it was just so complicated. The success rate was very low back in the 1970s and 80s. So podiatric surgery actually demonstrated, because I'm not sure what day, don't quote me on this, but the first podiatric surgery in the UK was done in the late 1970s. And I don't know the person's name, but he's one of the first podiatric surgeons who actually said, hang on, I'm going to do this surgery. And he got, it was a legal loophole where he could actually do it. That was the first surgery that was kind of performed, and it was successful. And then the General Medical Council came into play, and it became sort of like a court case where they were saying, hang on, it's illegal what you're doing. And then he actually proved it's not, what I'm doing is operating, I'm actually doing everything legally. And what's interesting in the article I was reading is they didn't budge, because he was like saying that if they actually budged, it would have been game over, but it didn't. That allowed scope of practice to emerge. And from there, it's just been, I mean, even from the last 10 years in the UK, the amount of new surgeons that have come up, I've got, colleagues and friends who've now are podiatric surgeons, they're on that, and they've done great research, they've written great papers. It's really like gone to another level. I mean, what about in the US? When was like the first, because I was watching a podcast with, I think, Dr. Harkless, he was one of the first people involved in the Texas classification, in fact.
He could literally write the history book of podiatric surgery, not only in Texas, but throughout his lifespan. So yeah, I mean, he's seen it all. And he's helped push that scope of practice in Texas to get to the point where we can practice to the level of our training. And he helped start a new podiatric medical school in South Texas that Javier LaFontaine, one of my colleagues, is now taking over as the dean. And it's ingrained in the University of Texas system. So it's very much a big part of the future of medical training here in Texas, which is great. And I know that in California, the California podiatric medical schools were working with the state to try to get podiatric surgeons the physician and surgeon certificate, which would put them on par with any of the other MDs and DOs without a limited license. And part of that process required that they looked at the training in the schools, looked at the training in the residency programs in California, and it was a very favorable review. And I think that's going to keep pushing that forward so that we'll have parity with MDs and DOs when it comes to scope of practice.
Yeah, it used to be that podiatry schools were standalone entities. But now I want to say all of them have joined a medical school. So you're sitting in the same class next to MDs and DOs, learning everything the same for the first 2-3 years up until you start bridging apart and doing your podiatry specialty problems, pathologies. And it makes it simple. So when you're taking your boards, your USMLEs, I mean, when we're starting off of the USMLE guidelines. I'm watching the same classes, same courses, as if I'm starting for the USMLE step ones and stuff.
And they're working on allowing us to take those tests.
Yeah. And
I think that's where it's headed. Yeah. But I agree with you. I wish the reciprocity across the globe was better. I'd love to be able to have the same scope of practice in Spain or Mexico, France, and be able to provide care, even if as a semi-retired podiatrist, it'd be great.
I mean, I just did a podcast with a spine surgeon based in Miami, and he worked in places like in Italy, and he obviously was doing training there, but in the medical field, you could go anywhere in the world pretty much. Obviously, you need to get a license, but I think that's one thing that was kind of, I won't say disadvantage, but the thing that kind of closed off, because in the Commonwealth countries, because in the UK, we can go to Australia, Australian podiatrists. I've worked with Australian podiatrists who come to the UK. I've only known of one British podiatrist who went to Canada to work, and I think he had to do some exam. But I think it's easy within Australia, the UK, New Zealand. They're kind of like on a similar sort of like system. But even in Australia, they started a DPM program, which kind of follows the kind of US system. It's a 4 years DPM.
Yeah, and I think that has created some issues with, where do they fit into their system? I don't know if it'll happen in my lifetime, but we really need a more global standard. Yeah, I agree.
Mind you, there are actually 2 colleges in Scotland, but their Scotland system is weird because it's the United Kingdom. England, Wales, and Scotland. Their university is 4 years, so then the podiatry program is 4 years as well. So you get actually more time. I was about to study one of their universities, but I stayed in London where I studied because I wanted to commute from home where I lived. That was the only reason I studied over there. But it's interesting because it's 4 years. They've got a better system where you do all your studies, because we have, I think you call them thesis, we call them dissertations in the UK, where you do your paper. So you come back and and all you're doing is that thesis, and you get a lot of time to work on that. So that was quite interesting as well.
I like the fact that in Europe, research is a big part of your training, because it's not so much as part of ours. I think there are programs where it's probably more emphasized, but it's not required. I didn't have to do a thesis to graduate. But I think that's why you can get MD, PhD programs where they actually get a chance to do that research, which I think is fantastic. Most of the surgeons that I worked with in Russia, were MD, PhDs, and had tremendous research backgrounds and continued that in private practice. So
the thing is, in the UK, everything is heavily on evidence practice, evidence-based practice and clinical-based practice. We have it's called it's a guidelines basically. It's a clinical sort of like base that we use. There's a website, there's a lot of documents there, and it allows us to use it as it's sort of like we can quote it. There's a lot of things with diabetic care. It changes all the time, so keeping up with that actually helps clinicians. And
you guys have a tremendous use of information technology as well, and you're able to call that data, I think, sometimes better than we can, especially those of us who aren't part of the Veterans Administration. So the VA, all the military hospitals have the same database system.
Oh yeah, I can attest to that. Yeah. I did a little time at the VA up in Long Island. So we have full access to up-to-date PubMed, Cochrane libraries, Elsevier. I mean, all that stuff is at your fingertips, literally through the medical dictation portal. So I'm doing the patient's notes, and I'm like, let's type in, Pseudomonas aeruginosa. Let's see what the gold standard treatment for that is, right? Boom, click it, and it gives you everything. It was like knowledge at your fingertips. It was beautiful.
Well, they've also been using an electronic medical record forever.
Yeah.
And we still have folks here in Denton who are still using paper. So, that's one of the issues we have.
I remember when I just graduated after 2014, then I was working as a locum, and I was in a place where they were actually transferring from notes, paper-based notes, to computer. So we had to write paper-based notes, the whole filing system, and also do computer-based notes. And that was too much, because in the morning I had to go and get the files out, basically, because they were in the same room. Then write everything down, do the computer-based, go back, refile everything back. It was like...
Ouch.
After a month, I kind of got used to it, but it's just anything's possible.
Brutal.
I mean, no matter how difficult it is, the more you do it, the easier it becomes. You just kind of get used to it.
Yeah, there was a transition a couple of years back where the U.S. pretty much forced us to go to electronic medical records. For all those people that were using paper notes still, you actually had a penalty for still doing paper notes.
Yeah, I've been on electronic medical records since 2003.
Yeah, you were the original hipster on that. So I do know some people that were using paper notes back when I was in training.
I believe this is an American software called Cerner. I don't know if you've heard of that name before.
Yeah,
because I saw it.
C. Yeah.
CERNER.
Yeah.
Yeah, we use that's one of the softwares I would use. I knew it was an American system because when I was learning it was based in the US, so I thought it would be quite popular over here among physicians as well.
We're on Athena for the office, but the problem is right now we're on staff at 4 different hospitals, and every one of them has a different system. So we literally have to know 4 or 5 different electronic medical record systems.
That's the same of when my last job.
Yeah,
I feel you on that. There were like 3 systems.
So what's the lifestyle of a UK podiatrist like? Is it private practice, hospital-based, mixed?
Mostly hospital-based, because a lot of people come in looking for a stable career. And what's interesting is like a lot of nurses have actually gone to study podiatry because it's easier for them. They want a 9-to-5 kind of like career, and podiatry kind of ticks that box because nursing is quite demanding. Sometimes they're doing night shifts and they can't do it anymore. So that was quite, because when I was studying with a lot of nurses in my course, and it was a course full of more mature students, so that was one of the main things, stability. And then other people who actually want to go into private practice. I had a colleague who I graduated with, and she was married, so her husband actually bought a practice which already had everything in there. So they had some other, I think, a physical therapist already. So she just came after graduating, she took over that, and it was just easy to do because I already had the list of patients.
Yeah, I think
some of these private practices earn a lot of money actually. I worked in one, another story for another day, but it was just covering for a short period of time. So I could see how much he was making. Obviously, he wasn't paying me that much, but in a day you could rake in probably about $1,000 at times.
I think private practice in the United States is still probably more financially beneficial than being employed by a hospital system, but it's becoming more rare because places like California, Oregon, Nevada, Arizona, Florida, most all along the East Coast.
Yeah.
You're seeing fewer and fewer private practice physicians.
They're getting
it's really hard to keep up with the overhead. Yeah. But in Texas, we like to still be on our own as much as we can. I've had 23 years of not having a boss, and I kind of like it that way. So I'm trying to stick with this for as long as I possibly can.
No, I feel that. And I also thought about that too, because I was thinking, okay, you don't have a boss, but then you've got to come in the days that your patients are available. And most of the times, a lot of patients, clientele would like to come on the weekend. And I was thinking, weekends I would like to be off. So that was one of the main
Well,
issues, not
we're
issues,
off
but
on weekends for the most part, and patients find a way to get in to see us from 8:30 to 5, Monday through Friday. So,
but then if you're in an area which doesn't have many podiatrists, so
Mhm.
they've got no choice but to come on weekdays. I suppose if you're in somewhere like California, people want to be seen in the evenings after work, or perhaps a weekend, so you've got to kind of adjust for that.
that's true. Yeah, I think living in California is a lifestyle choice. It's going to be a little tougher, for sure. Yeah, but
And there are a lot of podiatrists around, so
because you got the schools there. Yeah,
2 schools there,
Yeah.
and a lot of people have already established practices here or have the reputation established already, so it's more difficult. I've seen that pattern where people who graduate, even in dental school, they'll go off to another state, which is completely different from the state they originally studied from. Obviously, if they're in New York, California, they'll go off to an opportunity would emerge where they can start a private practice or become an associate.
Mhm.
Obviously, living costs are much lower, so obviously the profit margins are opportunity much higher because you're living on a small amount.
Yeah, that's pretty much my story right there. I'm from New York. Yeah. I was like, I'm not going to practice here. I'm coming to Texas where everyone's kind of spread out. So competition is much lower. Plus no snow.
How are you finding it? The move from New York to Texas, obviously been there for a couple of years now.
So I'm from upstate New York, so about an hour north of the city. Very similar lifestyle as it is here. If I was in the city, it's a big difference. I lived there for about 4 years. I'd say if you have a family and you're trying to establish yourself, you got to be in the suburbs. It's hard to be in the city. There's so much competition there already. And I'm sure it's the same thing if you're in like downtown London versus the suburbs. Lifestyle, you know, I have kids, I got a wife. It's much more comfortable to be out here in the suburbs.
Yeah, and that's one thing too. I mean, I see a lot of other physicians working so many long hours, and the main thing is like, because I used to work in the diabetic foot clinic, we're community based, so we're there 9 to sort of like 5. They would come in and sometimes we get referred for a patient. Can we leave this patient with you now? I'm like, no, we're going to finish up now. We're not. Sometimes if you explain to them, we're not hospital based. We're community based, so our commission is with the community, and that's our sort of ours. But if you were in a physician specialty, you'd have to be there until the patient, you actually diagnose the patient, did your treatments, etc. So I've got some colleagues who are physicians and they work like long hours. You know, I had just last year there was one vascular surgeon I was working with. He just literally came from a shift from another hospital. You know, it was like 24 hours, like working 48 hours almost.
We have some of those issues here as well. One of our vascular colleagues, I like to joke that he haunts the hospital. He's there so often. But, you know, you can limit those things by developing groups and sharing call. And, you know, certainly we've been able to avoid some of those issues where we're being asked to be, you know, available 24/7, 365. Although we do take call, the vast majority of the things that we do in the lower extremity don't have to be done right now.
Non-emergent mostly.
Yeah, I mean, unless it's a raging infection, you know, we can deal with it tomorrow, and so the ER will stabilize, get him admitted, and I can go see him the next day. But that's one of the advantages
that's
of
the
our
good thing, I believe.
Yeah, absolutely. I mean, I think it extends the length of your career because you're not a stress case for 20 years.
Yeah, you can get burnt out easy.
I did all the call. I did all the crazy call for the first 8 years. And then I was like, nope, not doing that anymore.
But mind you, though, it's not the amount of hours you do, it's the work you do. I mean, I've been burnt out just doing 9 to 5 because you're trying to see a lot in a short space of time. Like, you know, sometimes you want to spend more time with a patient. If there's sometimes a diabetic also says severely infected, you know, you need to get antibiotics. So usually it's half an hour slots we get.
Right.
pandemic, they allowed more time per patient. But sometimes you can go over that time and then you're running late in your clinic. So it can be quite tiring. I mean, one of my other colleagues who was basically almost like my mentor, I was working under him. He was working for scope of practice as a physician himself. He was a podiatrist. But other departments, other doctors would come in and be like, wow, they go, you're doing so much over here. They go, you're pretty much a full MD physician, because you're giving antibiotics, you're doing other things, you're taking bloods, you're testing for blood glucose, you're using all these other machines. And that, he was always like, kind of like, and then going home, he would have to prepare the case studies for the next day, because in the morning we'd have like a multidisciplinary team meeting where everyone would come in, like from all departments.
Wow.
Who were involved with some of the patients. So I was with him all the time, and I'm like, this is quite hands-on.
Where was this?
This was in West Middlesex Hospital.
Okay.
And he actually did the theory of podiatric medicine, and he was also a trainee podiatric surgeon, although he didn't continue his training for that. So he was like one of the best podiatrists I've ever known in my life, because his breadth of knowledge was even higher than many podiatrists, because he actually did some other courses and he worked with nurses and other paramedics, and he kind of was like, wow, the amount of knowledge in podiatry, like, because if you don't use it, you kind of lose it.
Yeah.
A lot of podiatrists don't really, even if you've learned it, you're going to actually lose it to know general medicine, from the heart to the kind of like arteries in your neck, and it's the whole system. So he would shock everyone because he knew his stuff inside out, to a point where they were like, whatever you need, we'll just sign it, whatever meds, because obviously podiatry, you're limited in terms of medication that you can prescribe.
I think our scope of practice here in Texas is we treat the foot by any means necessary. And that gives us some latitude. And I think it forces you to make sure that you're spending your entire career learning. And if you aren't, I agree with you, you're stagnating, you're going to forget this stuff. Dr. Hussain and I work up our own patients for surgery. We do complete H&Ps. We're able to fully prepare a patient for a surgical procedure. Now, we're not managing their medical problems. That's what their primary care doctor's for. But we're making sure that what I'm doing is not going to adversely affect what their chronic medical conditions are requiring, and vice versa. And so it's a team approach. I think the team approach is so vital with what we do for a living, for sure.
Here we have what's called continuing medical education courses and classes. We have to get a certain number of credit hours per year, or I think it's actually technically every 2 years.
Yeah, we've got the same as well. You've got to keep up to date, because once they can audit you, the licensing body, every year they randomly audit some people, and if you're not up to date, then you can get in trouble. Right. So you need to keep that in your folder. It could be this could be CBT, basically continuous. If you documented 1 hour, if you signed like a paper, like there's been situations like that where people have, had meetings just casually, and they've actually kind of just written what they learned that day and then put it into the folder. So that could also count. You can do courses.
Yeah, thankfully we've got lots of opportunities online to kind of augment some of that.
Yeah. I just watched one yesterday on lymphedema.
There you go.
No.
We're seeing a bunch of lymphedema.
Do you do any lymphedema sort of procedures or any treatments or management?
Thankfully, we've established a relationship with a lymphedema therapist through our wound center. And, that's been a constant problem. I think the availability of those folks with expertise in that is limited. And it can be a huge part of why your wound.
Issue here.
You know what? It's tough. It really is tough.
It's a lifelong problem.
and it's not going to go away. We ended up, I think, kind of falling backwards into this relationship with this lymphedema therapist, but she's willing to come to the center, meet with patients, establish a plan. Because until you get rid of the edema, or at least you get it under control, I've got no chance in healing some of these wounds. So we're going to foster that relationship for sure. I just referred to more patients.
Patient.
What's that?
As you're saying, I keep picturing his patient. Unfortunately, passed away last year, and he had severe lymphedema, where the legs were just massive. I mean, if I had pictures, you could imagine
such a difficult condition to treat and manage. It requires a tremendous amount of work from the patient, and the pneumatic pump systems aren't as easily available as they should be. We have to jump through unbelievable hoops to get these in the hands of patients who really need them.
Yeah.
And it's clearly more expensive to treat the chronic wound problems than it is to put one of these pneumatic pump systems in the hands of some of these folks. But, we're trying to learn.
That's what it comes down to sometimes.
Yeah, absolutely.
It's the cost aspect, like sometimes it's actually cheaper to do a procedure which the perhaps insurance company they're not happy with, because the alternative, if it gets worse, is going to be more expensive. I think the saving capital is within the NHS, because although we don't work on a profit-based system, it's actually outcome-based, and you've got to do a certain amount in a year, procedures, etc., to kind of meet that budget.
I think you're hitting the nail on the head. The way our fee payment system here in the U.S. is still based on churning them out. And until we truly get to a place where you're reimbursing people for quality care and making that worth their while, you're still going to have issues where whatever might be the best thing for the patient is still being denied by the third-party payer. And the complications from treating wounds poorly are so unbelievably more expensive than treating them well. And the data is there, but this is just not the way the system was built. The system's not built for preventative care. It's not built for preventing recidivism. It's built for doing procedures. And we've got to fix that. But we still have to make it worthwhile for smart people to want to do this for a living, because we're already behind the 8 ball. We don't have enough people who are interested in diabetic foot.
Or medicine in general anymore.
But particularly diabetic foot. I mean, we're already so far behind the tidal wave of people that are developing type 2 diabetes and will be at risk for limb loss in the next 15 to 20 years. If we're not churning out people who are interested in treating those folks from all specialties, but primarily those folks who deal with lower extremity wounds, the amputation rates are going to explode. And it's going to be sad.
I mean, they already are.
Yeah.
I was looking at some data from the last 10 years, and I can see the amount of, especially in my hospital where I used to work, I mean, that was just devastating to see someone come in. We're trying to debride the wound, obviously offload it. We've been trying everything, working with nurses also coming in. And then after 4 or 5 months, just cutting down bone infection, osteomyelitis, seeing the pictures as well, like to a point where the fourth was pretty much gone, and it's a domino effect. Devastating.
Yeah, I'm really proud of what we've been able to do here in the Metroplex. We have a number of really good wound centers, all different hospital systems. But I think we're doing some really good wound care in the Metroplex. But this wound center that we've started at Wise Argyle is 3 weeks old, so it's in its infancy. But I think it's going to be a big part of the medical community here, and I think it's going to save limbs and save lives every day. Actually, that's where I'm headed as soon as we get done, because I've got 4 patients to see there this afternoon.
Wow.
Well, this has been great. We really appreciate having you on the show, and we need to touch base with you again and talk about some more specifics of how things are going out there in California.
Yeah, no, it's been fun doing this, and I'm sure I'd love to come on to some of your other podcasts for other case studies that you demonstrate normally.
Oh, absolutely.
Talk
Yeah, of
about
course.
different aspects of your podiatry practice.
Yeah, we're constantly videotaping our cases, and we would love to have you on and go through, one of these surgeries and just go through it from A to B, and talk about what our approach is, why we decided to do X, Y, and Z. Yeah, I think that'd be awesome. Let's do that. Let's schedule that.
Oh, well, I love that. Thank you for
You
that.
bet. Well, Ram, thanks again, and Dr. Hussain, thank you. We'll see you guys next time on the Pod Doctors.